Good evening, everyone. Good day, wherever you are. Can you hear me?
Yes. Yeah, I can hear.
Okay. All right. Thank you. So I will hand over to Chris to say a few words before we continue.
Sure, hey everyone. Sure, I did not expect to be saying any words. I'm kind of just here as a spectator. But I do wish all the teams a good luck. And for all the individuals who are participating as the audience members, I'd like you to keep in mind that this is a good opportunity to perhaps get inspired and to know that for our next Ideathon, it could be you presenting and potentially winning some hundreds or thousands of dollars. Cool, thank you. Enjoy.
Thank you, Chris. Okay, so I see our judges have joined and some of our participants from the teams have also joined. So good evening, everyone. Good day, wherever you are. My name is Daphne, and I've been part of the Ideathon team, which was organizing for the 2023 edition. Because of our time, I think we can start with our teams. So I'd like to know if the teams are already here. So for Team Helix, do we have our representative already signed in?
What Team Helix?
Hello, everyone.
Okay, so it seems the teams are good to go. Okay, so because for the sake of our time, we'll start. So each team has got 5 minutes to share their screen and give us what they have concerning the idea that they've been working on. And then after that, you are going to be timed for the 5 minutes. And after that, we'll hand over to the judges to ask questions. Again, we'll have 5 minutes for the judges to ask questions. And then we'll hand over to the second team to present after that. So
Okay.
Best wishes to all the teams and keep the time for 5 minutes presentation. So we'll start with Team Helix.
Okay.
Over to you. Okay.
I don't have access to share my screen. Hello, are you hearing me?
Yes, I can hear you. Let me sort it out.
I don't have access to share my screen. Okay, it's okay.
It's okay now?
Yes.
Yeah, okay. Go ahead. Sorry for that.
Okay, let me. Hello, everyone, and welcome to our presentation. I'm Chelsea Lomo, fourth-year student at National Advanced School of Engineering, Yaoundé. In the 5 minutes, I will share with you our project, which is talking about optimizing the detection of risk factor related to transfusion reaction in African hospitals. I divided this presentation into 3 main parts. First of all, I will share with you context and problem. Secondly, I will explain the idea. Finally, I will talk about the impact we will achieve with our project. Let us start with the context. A public health problem affecting millions of people worldwide and in Africa. According to the World Health Organization, 112.5 million blood donations are collected each year worldwide, including 9.3 million in Africa. According to the World Health Organization, Sub-Saharan Africa is the region of the world where the risk of infection through blood transfusion is the highest due to the lack of resources, qualified personnel, and quality systems. World Health Organization recommends systematic screening of all donated blood for infection prior to use. Screening should be mandatory for HIV, hepatitis B and C, syphilis, and carried out according to a quality assurance system. All of the country reporting data, 10 are unable to test all blood for one or more of the infection listed below. In relation to the previous context, 1 in 4 low-income, a recent study conducted by Dr. Buashi showed that 95 out of 200 patients reacted to blood transfusion. The problem that arises is the increasing incidence of allergy reaction after blood transfusion in hospitals in Africa. Then, our idea is to build a high-risk factor detection system that will identify at-risk donor and patient at risk of developing severe post-transfusion reaction using historical data for each of them. We realize that 1 in 4 low-income countries doesn't test all blood donation, and 54% of countries do not have safety system to secure supplier chain from blood donor to patient. Here is the impact we would like to achieve. The first one is reduce morbidity and mortality of transfusion patients by preventing severe or fatal allergy reaction. The second one is improve transfusion safety. Remember that 54% of countries doesn't have safety system to secure supply chain. Then you will identify high-risk patients and take appropriate measures to prevent adverse reaction. The next one is resources pooling. Resources pooling by identifying donors with risk factor. Their participation can be useful in other programs like plasma donation, rather than excluding them from the blood donation program. The next impact is to reduce the costs associated with treatment. The management of patients after post-transfusion reaction, often costly for low-income countries. Then, by reducing the number of high-risk patients, it will be drastically reduce hospital stay duration and consequently decrease the economic burden on the healthcare system. How can Sisonke Biotic can help us? Sisonke Biotic can help us by giving access to data related to our geographical area so that the model trend is not biased. They can also accelerate the development of standards on the ethical use of AI applied to healthcare. Sisonke Biotic can organize campaigns to inform the public about advantages of having such a system in the hospital environment. They can also set up a team of HIHA experts and medical staff to initiate project continuity. Next one is to strengthen allergy monitoring and prevention by promoting the use of information system. The last one is partnership with hospital for pilot tests. We are Alex AI team, and thank you for your attention.
Thank you so much. Okay, before I hand over to the judges, I would like to thank all the judges for the work they've been doing, for the time that they've dedicated and I would like to introduce the judges to everyone. We have amongst us Dr. Amit. He is a senior scientist, U.S. National Institutes of Health. We also have Dr. Michelle. She is part of the DSI Africa. She is part of the Africa Coordinating Center. She's at UCT. And we also have Anthony Ndolo. He is from Deep Learning and he's also an organizer for Indaba X Kenya. We also have Messi. Messi is a research scientist at Google Research. So would like to thank all the judges for taking their time to be with us for this Ideathon for 2023. And thank you also once again to all the teams for being here and for taking your time for this Ideathon. So I'll hand over to the judges to ask questions to Team Helix. So over to you, judges.
Hi, Chelsea. This is Amit Mistry. Thank you so much for a really nice presentation. I just had two questions. One was, can you explain more about what geographic area focus you're aiming for, and like how big is the target area? And also two, can you talk a little bit more about the types of data that you're looking for access to? Thank you.
Please, can you repeat the question? I don't understand it very well.
Yeah, so first question is, what is the geographic area that you're wanting to focus in? What country or what part of a country?
The geographical area is sub-Saharan Africa.
The whole continent, or are you thinking of starting smaller?
In which country?
Yeah. Are you thinking of one specific country to start, or are you looking for the whole sub-Saharan Africa?
No, we're looking at Ghana country and Cameroon because we have some information in the hospital in this country.
Okay, thank you. And what type of data are you looking for? Hospital records or other types of data?
You want to know the type of data we like to have, or I don't know.
Yes.
The type of data is how can I say it? The historical data of the patient.
Okay.
When I talk about historical data of the patient, is genetic. How can I say it in English? Is I don't know how to explain it very well.
Yeah. Can I help with this question?
Yes, go ahead.
Okay. So you asked of the data that we'll be using, and we'll be using historical data. And this data will include the allergic things that cause allergy to patients when blood transfusion is going on. So we'll be collecting data on those things. An example would just be like whether this patient will react when these data, or like when these characteristics that data we collected align with it, whether the patient will react or not. So this is the kind of, it's going to be a historical data.
Thank you.
Thank you.
I'll defer to the other judges.
Thanks, Amit. So I'll just ask, I'm looking at the slides again, and it says that you want to build a high risk factor detection system. Do you want to just say a bit more about what that would take the form of, Would it be an app, or would it be, what would it be? You know, maybe you can just talk a bit about that.
Yeah, and just to as you prepare to answer that, I think my question is tied to the to that question too. What is the AI in your project? Thank you.
Anyone from Team Helix to respond?
Yes, please, Abdurrahman. Please, the question you said, where is AI in our idea, if I'm right?
Yes, and it's tied to what Michelle was asking. So,
Okay. So the AI in our question is the data that we are collecting is what we are going to use to train the model to be able to predict or to be able to tell like which patient will be of risk in blood transfusion. So that's where our AI comes in, helping in telling or like in predicting who will be allergic or who will what reaction to blood transfusion. Thank you.
Okay, thank you. Any other questions? Okay. Thank you, Team Helix. So if there are no more questions, we'll hand over to Team Safe AI Africa, if there is any representative.
Thank you very much. Thank you.
Thank you.
Team Safe AI Africa.
Yes, we are around. We are around here.
Okay, so you have 5 minutes to do your presentation. You can share the screen.
Yes, my colleague is preparing to share the screen. Yeah, here is the Team Safe AI Africa, which is an initiative dedicated to sharing advancements and approaches to safe use of AI in Africa and advocating for responsible AI use. Let's share.
Hello?
Okay,
Yes, I'm sharing the
are you
screen
ready?
now.
Okay.
Yes.
So as you share the screen, I would like to welcome the other judge, which is Eku. Thank you for being part of the Ideathon final.
Thank you. Hello.
Yes, we are waiting. You can share the screen. No, we can hardly hear you.
You see my screen?
Not yet. Yes. Go ahead, you've got 5 minutes.
Hello.
Yes, we can see your screen.
Hello?
We can see your screen. You can present. We're waiting for you. Is there any other member who can assist? Okay, maybe we can try the other team, Team Sankofa.
No, we are sorry. I'm having issues with our network and the laptop has somehow crashed. I don't know what's wrong. We're trying to rectify that.
Okay, it's okay. You can work it out and we can maybe introduce the other team while you sort the issue.
Okay.
So if Team Sankofa is there, you can start sharing your screen. Sorry, is this Team Sankofa?
Yes.
Okay, all right, great, thank you. So you've got 5 minutes, you can start presenting.
All right. Hello, ladies and gentlemen. My name is Emmanuel, and I'm presenting along with my team, Team Sankofa. So first off, I start off with a story. Imagine this, that you woke up one morning to find a small painless bump on your skin, and it seems harmless, perhaps a bug bite. But as days pass, it grows, becoming a painful ulcer, and you're unsure and worried. Yet you hesitate to seek medical help because you fear judgments and whispers from those around you. This isn't just a hypothetical scenario. This is the silent reality for many in rural Ghana suffering from Buruli ulcer, which is a treatable condition that's often cloaked in stigma. Early stages of this condition usually resemble other skin diseases, making accurate diagnosis challenging. And microscopy, which is the primary diagnostic tool, is only 40 to 60% sensitive. Advanced methods such as PCR and histopathological examination are also very expensive. And in rural areas, people tend not to have access to these diagnostic tools. Unfortunately, diagnosis is also usually restricted to research projects, without which accurate diagnosis is usually not made. And the issue isn't just medical, it's also a societal one because of the stigma attached and then the significant financial burden it poses. So in 2022, Ghana reported 17 cases of Buruli ulcer, and currently Ghana is classified by the WHO as an endemic country. But we believe the number that has been recorded is just the tip of the iceberg, because there are many cases in rural areas that go unreported due to the stigma, with victims avoiding medical attention. The true prevalence somehow seems to be hidden as the disease progresses, because it inflicts devastating physical damage and then compounds societal stigma and also imposes financial burden. So addressing this isn't just about the health, it's also about restoring dignity and hope. Our goal is to develop a software that will slow down the development and effects of Buruli ulcer, also reduce health costs and stigma. And we hope to have our software included in Ghana's healthcare system.
So our implementation will be in 2 phases. In phase one, yeah, we are relying on the power of data technology and artificial intelligence. Rather than relying solely on traditional diagnostic methods, we propose a system where patients can use everyday devices like smartphones to capture and send images of suspected BU lesions. patients send photos of potential cases, which prompts a request for a brief clinical history. After uploading essential clinical history, such as lesion onset, itchiness, pain, and accompanying symptoms will be obtained from the patient. This approach connects patients with physician care they would otherwise not have received. In phase 2, image data from phase 1 will be annotated by the physicians and added to a database. We will employ the collected data to build a convolutional neural network-based image classification model.
I'll take it from here. To make this vision a reality, we need support. Funding will drive our initiative, while collaborations can connect us to a broader community of dedicated physicians. Additionally, robust technical infrastructure is crucial to store and process our data securely. Of course, we would have challenges, and some of them that we've noticed are physician and training, data quality and consistency, as well as privacy concerns. Imagine a Ghana where no one hides their skin out of fear, where Buruli ulcer is detected early, treated promptly, and eventually eradicated. Our software could be the cornerstone of renewed public health strategy against this disease. Together, we have the power to eradicate Buruli ulcer and bring hope to rural Ghana. Will you join us on this transformative journey? Thank you.
Thank you, Team Safe AI. All right, so we'll hand over to one of the judges who just
Excuse me, that was not just AI. We haven't presented.
Oh, sorry about that. So thank you, Team Sankofa. So we'll hand over to Dr. Seko to be the first one to ask a question, and then the other judges can ask questions.
Okay, thank you, Daphne. So thank you, Team Sankofa AI. I have a few questions, but I think I will start with this one. Is your goal truly eradication of Buruli ulcer, or is the goal to reduce the impact or reduce the effect of it?
So mainly our goal is to be able to diagnose the condition very early so that it will aid in the treatment of the condition. And in effect, we are going to significantly reduce the burden of Buruli ulcer. And if, as we reduce the burden, we are able to eradicate the condition, then that would be great. But then mainly our goal is the early diagnosis and then treatment. That's our goal.
I think that it would be important for your team's presentation to differentiate between the process to eliminate or to eradicate a disease and the process to minimize the impact through early diagnosis, because they are two different things. And I think that, as you described, everything that your team has proposed will be targeting the early detection, and you mentioned things like reducing stigma. If I understand that value proposition properly, it is being done because patients have the ability to discreetly communicate with their health providers.
Yes, exactly.
Okay. Do you know of similar projects that have been able to effectively bridge that communication between patient and care provider? And I guess from your team's perspective, do those projects give you encouragement that it can also work for this condition?
Hello. Yeah. So I think from our research, what we came across are papers that sought to diagnose skin conditions with a similar approach, but not really on an implementation level. So I think we haven't really come across anything that's working on implementation level.
Okay, it may be something to think about. But I'll pause there with my questions and hand over to the others. We can follow up as time goes on.
Thank you.
Daphne?
Over to you, judges. Thank you.
Yeah,
Over to the judge.
I'm happy to go next, but I see someone has their hand raised.
Yes, thanks, Amit. My question will be, I can see, I'm not a medical doctor, but I can see from what I've read before that Bureli is not only in Africa, sub-Saharan Africa, it's also affecting many people in the West, in Australia and the Americas, and even some few countries along the Western Pacific. So,
yeah, that's true.
My question would be, what technique you're going to use to identify or to identify the wound that is probably going to lead to Bureli, or what method you're going to use in that case. And by the way, thank you for highlighting this problem. And I also wanted to just make a quick comment that one of your pictures, you should be very careful when sharing pictures. There's a picture that is not really good in terms of exposing the private parts of someone. In this case, it's a small kid, I think. So check on that. You can use something to cover it just in case. But otherwise, you can now answer my question regarding what AI technique you're going to use to try to diagnose the disease. Thank you.
Would use convolutional neural networks. And basically, after the doctor, in phase 1, when the doctor gathers when the doctor receives the data and annotates it, that's the data we're going to use as a training data for the model. And then the model does the classification for us based on what the doctor says, or based on everything that has happened in the hospital. So the model ends up classifying the pictures as Buruli ulcer or non-Buruli ulcer.
Thank you.
Yeah, hi, this is Amit. My question, first of all, very nice presentation, very interesting problem that you're working on. I wonder if you could talk more about the prevalence of this type of cancer, and also, it sounds like it's more, you're targeting rural communities. Could you talk more about how you plan to reach the communities in rural areas? Especially, I'd love to hear more about your plan to.
Yeah, Amit, thank you for the question. So, as you said, yes, it's mainly in very rural areas. So our approach in collecting the data is, as we mentioned in the presentation, with how phones and
kind of reach out to get people to actually, participate.
I'm talking. How we could. Yeah, sorry, let's say something. I can hear. Is there something I can hear? Okay. Oh, sorry about that. Yes, our approach was if we have a portal, then for communities where they have access to internet, and then they can access that portal and share. But for communities where they do not have access, we are thinking of more. You could share these images through MMS, and if not, if we have contact with their local health facilities, then we could speak with, say, a nurse or a doctor who's there. They can be a consultant just for this purpose. So they see that only that physician, and then the physician gets the image and then shares it with us.
Just to add on to what he said, so the other groups that have already started working on Buruli ulcer, and so I've been able to map out endemic areas. So we were going to collaborate with some of these groups to be able to tell which areas are endemic. That's how we would locate the very rural areas that would be targeting to collect data from. Then secondly, on the prevalence, as we mentioned in our presentation, because it's a disease that's associated with a lot of stigma, most of them do not report. But then in 2022, Ghana recorded 17 cases. Those are the cases that have been recorded. However, we believe that there are more cases than the 17 that have been recorded because of the stigma associated with it. And as we all know, the incubation period for this condition sometimes takes about 4 to 9 months before the condition, the disease manifests as a debilitating ulcer. And most of these people tend to resort to herbal preparations and alternative medicine for treatment, and so do not report to a health facility where records will be taken. And that's how come we feel, not just feeling, but then we know it's underreported. So based on these two, we'll be able to now map out the areas and then carry out the research there. Thank you.
Thank you. That's helpful.
Over to you, Michelle. Thank you
so much. So I just wanted to, thanks so much. I just wanted to ask the team, sort of following on from what Seko asked, and just sort of the plan to bring this together, you know, recruiting a healthcare professionals to consult on this and be involved in the program. So have you, Seko mentioned like the proof of concept. Has anyone else done something similar? And I'm thinking, have you thought of like, and are they in the regions that you're working, are they sort of a health profession, like networks of doctors, networks of nurses that you could possibly tap into? Can you speak to like health insurance companies? Are those available? I'm just trying to think in a practical way how you would make this easier for yourself, reaching into existing networks, basically.
Okay, so as I mentioned earlier on, there are groups, for instance, there's the Kumasi Center for Collaborative Research, which is a research organization in Ghana that has a group working on Buruli ulcer. So we've started speaking with them to, first of all, be able to map out the areas that are endemic, and then to be able to reach out to those communities. Moreover, we also have doctors that we could talk to examine the images that will be taken from people that send their images as well as their clinical history, and be able to diagnose them of Buruli ulcer. And also I'm a medical practitioner, so I'll be able to link up with a number of doctors to help on this project. Then also in relation to the false positive and then the false negative rates, yes, we've considered all of that. So it wouldn't be something that diagnoses you and then all of a sudden says, okay, now you need to go for treatment, and okay, you don't need treatment. No, that's not what you are going to do. It's more of a clinical decision support. So what it's going to do is that it would pick out the very suspicious lesions and then recommend that you go see a doctor for definitive diagnosis and then treatment. That's if you would need it. But then if you would not need it, because it's a rash and then an ulcer, you definitely need treatment anyway. So you can receive that treatment as well. Because one thing we've also noticed is that most people tend not to go to the hospital for such treatment. And in developing the software and letting them know the consequences of what might happen if they resort to alternative treatments would, in effect, be able to direct them to the hospital for treatment of whatever condition it is. But I think when it comes to false positive and false negatives, we've considered that, and we hope we wouldn't get a lot of that. However, I think it wouldn't be a big problem like that. Then what are the challenges that the Ghana Health Service might have with our intended strategy? And then how might privacy and safety? So we've also considered the safety of the data and then the images. So one of my colleagues will talk more about that in terms of the encryption and then how that. So I'll let my colleague talk about the safety and then privacy.
For the safety and privacy concerns, we can store the images and all other information on the
To respond to that question.
okay on secure servers, and the data in terms of questionnaires and other stuff would be de-anonymized, and the pictures too will be de-anonymized for the data security and safety. But our main concern will be that the servers and all the places where the data are kept are encrypted and are secured. Thank you very much.
Okay, thank you. Michelle, are you answered? And Sekou?
I'm good for now.
Yeah, thanks.
Yeah. All right, thank you. So we'll have our last team to present for us. I hope you've managed to sort the challenge that you had earlier on. Team Safe AI, are you ready to present?
Hello, can you see my screen?
Yes, it's clear. We see it.
Okay.
Yes.
Okay, so our topic is about developing an AI-driven mental health chatbot for Ugandans to address mental health challenges. And so our objective is to highlight the need for such a solution and present its benefits. So these are my teammates. Yes, so first of all, what is mental health? Like when we talk about mental health. So this refers to the state of well-being whereby individuals can effectively manage life's challenges, they can work effectively and contribute to the overall benefit of the community. Yes, but the problem is that in countries like Uganda here, where we have other challenges like lack of education, poverty, and others, when we talk about mental health care, it may seem to be like a privilege, which not everyone can afford, sadly. So that is the main problem. Furthermore, it is a fact that, for example, a case study showed that there is a high prevalence of suicidal behavior that includes thoughts and attempts to commit suicide among adolescents in urban areas of Uganda. And on top of that, 77% of suicides take place in low-income countries, as reported by the World Health Organization. So, and we know very well that Uganda is among those low-income countries. And from this case study, 31% of adolescents reported suicidal thoughts. It was discovered from that study, and 24% having actually tried to commit suicide. So this is a serious mental health challenge that is faced. So why is it important for us to have that mental health chatbot? Already there is a very significant number of Ugandans suffering from mental health issues, approximately 14 million individuals. And what we hope to have with our mental health chatbot to bridge that gap between the limited resources, first of all, there are few professionals and also the stigma around mental health. People in Africa and generally in Uganda, there hasn't been much awareness about mental health. So that is a problem. And yes, it comes from societal bias surrounding mental health. And that hinders individuals from seeking the much needed healthcare attention that they need. So our solution involves having that mental health chatbot developed, AI driven. And so what we hope for this to be is to be an accessible and sort of personalized assistant, but not replacing the mental health professionals, just coming in to act like a help. And some of the unique features it has, that it's safe, it's an anonymous platform where you do not expect any judgment or feedback, and it's also very culturally sensitive. So our our chatbot, this is the demo that we have, and we have trained it to, let me just, maybe I'll show it at the end. Yes. So we have trained our chatbot with data from literature, peer-reviewed information that we searched about mental health, and also information from mental health professionals in Uganda. So what are some of the benefits that we already envision for our mental health chatbot? First and foremost, increased awareness and understanding of mental health. Many people, especially here in Uganda, they do not understand what it means by having mental health issues. And again, that will empower individuals to seek help without fear or judgment, because like we said, our mental health chatbot offers a non-judgmental space for people who have mental health issues to consult about, then also improve well-being and quality of life. So like I said, still in developing this chatbot, we trained it with information from literature, as well as information provided by mental health professionals. So one of them is Dr. Richard Mpango, who is a project leader at MRC UVRI in Uganda, a research unit where he leads the mental health, he's leading the mental health project since 2014. Yeah, so in conclusion, we hope that our chatbot will be able to provide safe, stigma-free support and education, bridging the gap, especially, that point is very important, bridging the gap in mental health services, offering the much needed timely intervention and reaching remote areas. That is part of what we envision in the future, and also collaborating, especially with mental health professionals, because we don't want, what we envision is that this chatbot will be like coming in to help to offer assistance, because to the mental health professionals, being like an added assistance, because like we said, there are few, and also accessing these services is sort of seems like a luxury. Thank you very much. Maybe if there is still time, I can try to show how we managed to train.
So unfortunately, your 5 minutes is up. We'll take questions. Yes, we'll take questions from the judges.
All right. Okay, thank you.
Thank you. Over to the judges.
Put a few questions in the chat, but I know that we're short on time. So I am open to the team selecting which of the questions they will choose to answer in the short run, and I'm open to follow-ups. And I will go back over the recording for the teams that I didn't get to ask questions for at the beginning.
Yeah, sure. On my side, we know that we have very few papers or research work that has been done on mental health in Africa, and it's good that you are zeroing down fast regarding the cases in Uganda. But I wonder how the data you are saying is about research papers that have been done in Africa. I don't know how we are going to improve on it, because we have mental health or mental illness can be classified differently. Even anxiety is one of them. So I hope your good team and the good work that you're doing is going to take in consideration of the missing gap, so that you don't have bias. So my question will be, how are you going to handle the data security of the patients, or somebody trying to, or a client that's going to use the chat box, and the privacy involved, plus the biasness? Thank you.
Yes, thank you. My colleague Xavier is going to answer that.
Sorry, I didn't hear well the question.
I was off my network. So
Yeah,
poor.
I'll repeat it very fast. Research, your source of data is research papers on mental health. Africa has a low turnout of such kind of papers based on the fact that many people don't want to report the cases of their mental status, just like in the case of HIV/AIDS. So if the data is not sufficient to give the proper picture of the cases, we might end up having bias on your chatbot rather. That is one. How are you going to handle bias of your chatbot rather? The other one is the data privacy and security of the information we're going to collect. Thank you.
Thank you so much for that question. Okay, like my colleague has presented, we trained this on a no-code machine learning platform. There are very many no-code machine learning platforms. So as we suggested in our pitch, we said we are going to leverage the pre-trained GPT models. So we have that GPT model, GPT 3.5, because it was cheap and we used that. Remember that the chatbot, especially, for example, I know most of you are aware of ChatGPT. It was trained on lots of data from internet. So it has that information of mental health, all information from internet up to 2021. I think they have even updated to 2022, 2023. It has that information. But for us, we focused on the chatbot being specific to Uganda and putting that information that is in line with the culture of Uganda. So that's why we got that information from the health professionals that are in Uganda that have been doing research in Uganda related to mental health. So it has that information that was pre-trained with it. So we are adding in this information, the local information for the chatbot to be so specific, you get. So on the side of privacy, of course, we are going to put in place a system of having the questions from our guests being in a well-protected database, such that no one can access the chats between our chatbot and the victims or anyone else. Yeah.
Okay, thank you. Any other questions before I read the ones that are on the chat?
Yeah, hi, this is Amit again. I think I would just echo some of the questions that Sekou mentioned, and I think it'd be interesting to hear more about, I think, what evidence you have that these types of chatbots can be effective in mental health. I think that's something that I think we typically think of mental health as requiring some sort of human intervention. It'd be good to hear just more about what evidence you have or what you know about how well it would work, and also your plans for adapting it so that it's more accepted in the Ugandan context. I think that'd be interesting to hear more about as well.
Yeah, sure. We have a plan already. We have a plan of that. We are building a website, and already we are working on it to make sure that we have this chatbot deployed on our website such that people can easily access it. And we have seen from studies, there have been some studies, and we have seen that they have somehow been effective in offering mental health care support to the victims, not like my colleague has presented. It's not replacing the professionals, but somehow helping people who cannot access the professionals. For example, like my colleague has presented, we have a problem of limited professionals. So anyone who has a smartphone, these days everyone is almost online, especially in Uganda, the youth there are most people who are suffering from mental health. So at any time they can access it and get help. So we are getting it on our website as a model of deploying it. We are going to finish up our website, then deploy it.
Thank you. Over to Michelle, if she has any.
I think the questions posed are quite comprehensive, so I'm happy to go with those as well. Thank you.
Okay, thank you. And then, Seku, did you get answered on what you wanted to ask?
I think that we will run out of time today on that one. So
Okay.
I have shared the questions. This particular project I know will be a tricky one because of the sensitivity of the topic. Not that the others aren't sensitive, but this seems to be the first one where you're directly having the ability to influence the actual thing that you're trying to potentially mitigate. There have already been examples of chatbots that have been aggressive, have been harmful, specifically in this topic. And you're already talking about this chatbot being used with a vulnerable population. The other piece is that putting this on a website, what makes them like, why would somebody go to this? Why would somebody go to a website as opposed to any other form that they're already engaging? But that's not one of the questions I had put in the chat.
Yeah, and plus there's
okay,
there's a lot of stigma.
For
There's a lot of
some
stigma
information.
related
Hello.
to the problem.
Hello. Hello.
Yes.
Yeah, go ahead.
So I would like to give some information regarding our project. We are having this project as part of our initiative, Safe AI Africa, where we share advancements in AI, then approaches to safe use, then advocating for safe use of AI in Africa. So the whole thing is about safety. So we have so much considerations of that.
Given those considerations, especially given what you've just said, you have a very, very steep hill to climb to be able to prove or to guarantee safety, especially given the fact that you mentioned using generative models as the basis for or at the core of your AI solution. It's not something that your team controls. So that part will be a challenge. Not saying it's impossible. I'm saying this is an awesome research opportunity, but know that since you are setting the bar high, you will have a very high burden of proof.
In essence, there's a lot of work to do so before it goes out.
Definitely.
But it's actually easy. We have been trying using these platforms. It's already, there are other chatbots that have been done that were trained on local data that's specifically for other purposes. So we have seen, we have collected and deployed for different use cases. So we are sure it is very easy to deploy it after training. Yes.
So just to be clear, easy to deploy, chatbots exist, no problem. Nobody, you won't have to convince anybody very hard about that. Easy to generate results that seem believable, no problem with that either. ChatGPT by itself has proven that. But chatbots have been used for decades. Eliza was the first chatbot that is being used in a mental health context, and it was probably the first popularized chatbot, at least based on what my memory of learning this space. But you're talking about using a chatbot and you're saying that this chatbot will be guaranteed to help in a mental health setting, given that companies have already had to pull down their chatbots because their chatbots were either toxic or harmful, meaning their chatbots actually were actively negatively impacting their users. That's not something that is an easy thing to address. Technically, yes, you can do it, you can have people using it, but the burden that you have, given that you're talking about a vulnerable population, and given that you're talking about something that can scale so quickly, you have a lot to be concerned about.
Oh, thank you for the great insight.
No problem.
Thank you. All right, so I would like to thank all the three teams for making it this far. Thank you for the dedication and for your time. And I would like to appreciate Comfort. She has joined the call. We have been working together as a team on this Ideathon, and I would like to thank Sean for advertising. He's been the one advertising and marketing, and the rest of the team for the support. And I'll hand over to Comfort to say something before we close the session.
Hello, everyone. First of all, I apologize for coming into this meeting late. I had exams to write, and I will definitely refer to the recording to catch up on the things I've missed. Just the few minutes I've been here, I've been able to learn a lot. And secondly, I'd like to remind every one of us present that this is the second Ideathon that Sisonke Biotech will be organizing. The first one was last year. The second one is data science, this particular one, data science for health, Ideathon, deep learning in Daba, 2023. Hopefully we get to do this next year, bigger and better. Yeah, you of course, for people that are not members of the community yet, you can join the Sisonke Biotech community. Just fosters health development and the intersection of machine learning and health in Africa. Next, of course, adding to what Daphne said, I would like to thank every participant for their cooperation and throughout the period of the Ideathon. And lastly, a very big thank you to Dr. Sekou, Amit, Michelle, and Dolo. We really appreciate the time and effort and all the learning that we get to do from all of you. So yeah, I am concluding this meeting, and if anyone has anything to say, I would really like, but then time has gone, and thank you everyone for being a part of all of this. So take care, everyone. Does anyone have anything to say before I end the call?
All right. Okay, thank you, Comfort. So before we end the call, I would like to say, maybe to mention that the results will be announced tomorrow. So we'll post the results tomorrow concerning this particular Ideathon. And many thanks to Chris and to the rest of the team and to all the judges once again and to all the participants. If there is anything.
Thank you very much. Thank you very much to all of you, to organizing team. Thank you very much.
I would like to remind the judges to wait for a couple of minutes after the call.
Thank you to all the presenters. Very well done. Good work.